Ya, está listo. Cualquier cosa para la gente, les voy a dejar el link en el chat para que lo puedan ver si es que lo quieren compartir, porque para esto hay que, para Zoom, hay que inscribirse previamente. Entonces ahí
Sí,
está, por si es que lo quieren compartir con sus colegas, ahí les dejé el... Y no pasó nada, se mantuvo bien el video de Jody. Así que estaríamos, ok,
súper
ya
bien.
hay 3 personas, 10 personas.
Ya, excelente.
Así que saludo a toda la gente que está ya ingresando al portal de YouTube. Acá vamos a estar recogiendo todas las preguntas después de la presentación de Jody para poder eh, hacérselas directamente eh, a la expositora. Así que bienvenidos y bienvenidas.
Muchas gracias a todos por conectarse. Voy a escribirle al Leo también para ver si se va a conectar pronto.
Hola Roxana, buenas tardes. Hola Sofi. Ah, ya, la actividad de procesamiento sensorial. Hay una actividad, eh, aprovechando el portal, eh, hay una actividad que va a estar, los exponentes serán Erna Imperatore y Gustavo Reynoso, que se llama Procesamiento Sensorial, Evidencia e Investigación Contemporánea. Esto se va a llevar a cabo el día 9 de septiembre a las 14 horas, hora chilena. Eh, Pueden ingresar a las redes sociales del colegio por Instagram o Facebook y ahí van a aparecer toda esta información eh, que se está llevando a cabo. Y el día viernes está también una actividad que van a llevar a cabo Jennifer también que nos va a acompañar, o sea, yo no voy a participar, pero va a participar Jennifer y también con una colega, Andrea Mirá, que va a hablar sobre infancia. También pueden encontrar ese link en las redes sociales del colegio.
Y si hay alguien, algún alumno de terapia ocupacional, también quería compartir que se va a realizar el sábado es a las 6, no, tenemos una hora menos que Argentina, ¿cierto? En Chile. Sí, a las 4 de la tarde, el día sábado, va a haber una transmisión de Realto, de la Asociación de Estudiantes, Asociación Latinoamericana
¿Verdad?
de Estudiantes, que también van a hablar de infancia. Así es que para los que les interese, hay información en la página de Facebook y en Instagram de Realto. Se llama Aula Abierta, que es una iniciativa entre la Clato y Realto.
Tenemos harta actividad en este mes. Septiembre partió con harto movimiento.
Harto movimiento, sí.
Ahí bueno contarles también que repetir un poco que el sábado también vamos a estar con la profesora Hernán Navarrete el Día Nacional de Terapia Ocupacional de Panamá. Y eso también creo que es de Realto, parece también, de la red.
Puede ser. Estoy recién mirando los mensajes. Muy buenas tardes a todos. Cariños, Vivi.
Pero
Cariños, Roxana Bravo. Cariños desde Panamá. Todos los
sí,
colegas. Muchos cariños. El Leo se va a conectar luego, entonces en honor a la gente que se ha conectado temprano, yo creo que vamos a partir a la hora.
sí.
Vamos a tratar.
Está, por si acaso, para la gente que se incluye por primera vez, hola Vivian, bueno, y desde YouTube también, desde Buenos Aires también. Comentarles de que todas estas actividades quedan grabadas y la pueden volver a revisar las veces que quieran en el portal de YouTube de terapia ocupacional basada en evidencia. Todos los webinars, que ya han sido varios y varias presentaciones también que se han llevado a cabo en esta modalidad, eh, se quedan grabadas en el portal de YouTube, entonces pueden volver a revisarlo y las veces que ustedes gusten.
Sí, lo otro que
Hoy
quería,
día,
el otro dato que quería dar era que en nuestra página web, en la página web de este proyecto, hemos subido, bueno, el link a todas las presentaciones, a los videos, y también he subido algunos PowerPoint. Entonces, yo creo que el PowerPoint de esta presentación probablemente también la voy a subir. Tengo que pedirle permiso a Jody. Y lo otro que ella ofreció en el video subir es subir como una sábana que tiene con el modelo de hipertonía que va a presentar ahora, que lo estamos terminando de traducir, así es que en cuanto terminemos, lo vamos a subir a la página web para que de ahí puedan bajar información. Y también, bueno, los invito a visitar la página web, ahí ya que estamos en comerciales, porque hemos subido harta información que puede ser interesante, por ejemplo, cómo identificar si los artículos son de calidad, qué bases de datos hay en terapia ocupacional, dónde buscar información, qué otras bases de datos disponibles existen, por ejemplo, en el área de rehabilitación. Entonces hay harta información que pueden bajar desde la página, así que los invito a revisarla.
ya son un minuto. Nosotros generalmente partimos de forma puntual, en honor a la gente que ya ha estado
Sí,
desde
voy a ver si
temprano,
está el Leo,
para
el
tampoco terminar
presidente
tan tarde.
del Colegio de
Así que
Terapeutas, a ver si es que acaso.
ahí está, señor presidente, un gusto, un privilegio, Mr. President.
Señor presidente.
Mm.
Ahí sí. Buenas noches a todos.
Hola Leo.
Oh, mana, hoy. ¿Y comenzamos a qué hora? ¿7:05? ¿O a las 7 nomás?
Yo creo que a las 7, Leo, porque igual hay harta gente conectada desde bien temprano.
Sí, hay gente en YouTube también temprano, igual le vi.
Sí, así es
Sí.
que yo creo que comencemos a la hora. Yui se va a conectar en 1 hora 35 más, que es lo que dura el video. Yo les mandé en el
Sí.
Ah,
correo
ok.
la duración para que traigan su café y un snack para que eh, estemos bien hasta que yo llegue. Sobreviviremos.
Sí,
Sobreviviremos.
vamos a estar, no va a haber pausa, Jenny, ¿verdad? Vamos a hacerlo todo de
No,
una.
sí.
Ya, vamos a hacerlo todo de una sola vez, así que aprovechen, vamos a partir en un minuto más, así que aprovechen de ir a buscar su té, su bebida, su café, tomar los apuntes necesarios que quieran, preparar las preguntas, así que, porque será 1 hora y media, un poquito más para poder trabajar en esta presentación. Y luego viene la ronda de preguntas, así que se viene una jornada bien interesante, bien entretenida y claramente muy enriquecedora con Jody. Claramente vamos a estar aprender mucho el día de hoy. Así que creo que ya estamos en la hora, Jenny.
Démosle entonces. Buenas noches a todos los colegas presentes, buenas noches colegas de Chile, buenas noches colegas de Latinoamérica. Bienvenidos a esta quinta jornada de webinar con la Universidad de Queensland, en este caso a cargo de la profesora Jody Copley. Vamos a ver manejo de hipertonía en extremidad superior y esta presentación, como les repitió Sebastián anteriormente, tiene una duración de 1 hora y media. Luego de eso va a estar la profesora Jody con nosotros acompañándonos para tener preguntas de forma sincrónica. Por ende, levante la mano el que quiera hacer preguntas al final. Y vamos a tener también pregunta y respuesta, por si quieren ir dejando algunas preguntas ya para el buzón, en pregunta y respuesta. Y la traducción puede ser simultánea, o ustedes le pueden preguntar directamente a Jody también al final de la presentación.
Eh,
Adelante, Jenny.
Eso, Leo, un millón de gracias. Gracias. Bueno, este es el último webinar de esta serie, así es que quisiera agradecer profundamente el apoyo que hemos recibido del colegio, a Sebastián, a Luciana, que se conectó desde Brasil, y a todas las personas, a cada uno de ustedes que han hecho posible que hagamos y compartamos un espacio en estos webinars. Así es que eso, Las personas que están en YouTube, si quieren hacer preguntas directamente a Jody, los invito a que se conecten a través de Zoom, porque ahí vamos a habilitar al final las cámaras y el audio para que puedan preguntar directamente. Así es que eso, 1.000.000 de gracias a todos y bueno, los dejo con Jody, que es más interesante que lo que yo pueda decir. Ya, vamos a poner entonces el video y vamos a partir. Espero que se vea bien porque tuve un problema técnico, pero yo creo que vamos a andar bien. Eso.
De nuevo. I am Jodie Copley. It's lovely to see you again. And today we're going to talk about management of upper limb hypertonicity. So what you can see there on the screen is the textbook that I have been a co-author on that was published in 2014. And this textbook covers upper limb hypertonicity for people across the lifespan. So right through from children through to older adults, and thinking about people who have had strokes, traumatic brain injury, cerebral palsy. The aims of our workshop today will be to understand some of the key assessments and how to set goals for people with varying needs across the lifespan, to think about measuring concepts like spasticity, hypertonicity, and contracture. So when I talk about contracture, I mean usually shortening of muscle and soft tissue. So often contracture at the muscle level, sometimes contracture of joints as well. So thinking about key assessment processes and then looking at a framework for this assessment and for making clinical decisions and choosing interventions. So we have maybe around an hour to cover these aspects today. Often I will do this kind of training over a longer workshop, over 3 days, and that will usually cover more in depth some of the assessment options like strength and movement training, casting, botulinum toxin injection or Botox injection, surgery, those sorts of things. Today I'll just refer to splinting in order to illustrate some of the concepts, but there is much, much more to learn. So when we think of assessment for upper limb hypertonicity, I feel that it's important to put that within a broader framework, because the risk is to become quite reductionist and think just about the upper limb and think just about the performance components of what that person is doing with their upper limb. And as occupational therapists, we need to put that into the framework of occupation and why that upper limb function is important and what it can achieve. So the International Classification of Functioning from the World Health Organization is a nice framework in order to situate different components of assessment and make sure that we link our assessment of body function and structure or impairment with the person's activities and participation in daily life, so that we're always linking those aspects and not just focusing on the upper limb. And the ICF also provides us with a prompt to think carefully about environmental factors and about personal factors that are really important to the success of intervention. And the personal and environmental factors are particularly important when we think about upper limb hypertonicity, because we know that hypertonicity, Hipertonía, requires lifetime management. People who have brain injury do not usually regain complete control and normal function of their upper limb again. There is always some compromise. The success of intervention, therefore, depends on a whole range of day-to-day aspects. So things like the client and the caregiver's past experience of intervention, so what they assume is going to work, what they assume the outcome will be, what their expectations are. It's really important that we find that out. factors such as motivation of the client and the family and other caregivers, the age of the person, particularly for older adults, what home supports are in place for managing the interventions in a safe way, and that's very important for this type of intervention, and in an effective way, and what are the priorities and attitudes for the client and caregiver. All of those factors are vitally important in terms of success of intervention. So we could all be the best occupational therapists in the world in using interventions to work on the person's upper limb. But if we don't think about and factor in these personal and environmental factors, then the intervention will often fail because it requires that lifetime management, and it needs to be very collaboratively decided upon and collaboratively implemented. So I would consider that all of that information is part of your comprehensive assessment. And there are some references there on the screen for some research that we've done that looks at how therapists think about that assessment and what information they gather in order to be very informed before launching into the intervention for the upper limb. So we try to assess then at the levels of participation, activity, and body structure and function. And as I mentioned already, for upper limb hypertonicity, we're often not using a normative framework in that we're not thinking that the person's upper limb function is going to be typical, as other people might be able to use their upper limbs in daily tasks. We're not trying to fix everything about the upper limb. What our aim is to make changes to upper limb function and structure only so much as it impacts on daily life goals. So the link between the upper limb function and structure and the daily life goals needs to be very explicit. And because of that, our assessment often involves evaluating upper limb position and movement in the context of daily life tasks that are meaningful to the person. Now, there are assessment tools that are available that look at upper limb capacity, that use standardized tasks like picking up a block or picking up a pen or those sorts of things that look at upper limb capacity. They're useful to some extent, but if you use this framework of prioritizing participation and occupation, then you'll want to look at the person's upper limb function in the context of the activities they want to do and the activities that they need to do. So we come up with meaningful daily life goals that are at the level that that person is able to participate, and then link their body structure and function assessment to those daily life goals. So for an example, if you have, let's say, a client who is a teenager with cerebral palsy, or maybe a young person who's had a brain injury, a daily life goal that might be important for them if they live at home with their parents or their family, that this person will be able to clear the dishes from the table each night after dinner and put them in the dishwasher, and do that safely so that everybody isn't doing everything for them all the time. If that's a daily life goal, then we would link that to our clinical aims for the upper limb. And so we would analyse that task of clearing the dishes and putting them in the dishwasher, and do that task analysis and performance analysis so that we know that what this client needs to be able to do are all of these upper limb functions. So they need to be able to actively supinate to mid position so that they can get into position that they can hold onto the plate with a lateral pinch grasp. And then they need to be able to maintain that and have enough upper limb strength to transport the plate to the sink, and maybe sufficient control of proximal movement and release of the grasp for placement of the plate in the sink or in the dishwasher. So we're analysing the task to work out what are the functions that are required, which will provide the priorities for our intervention, and also the outcomes or the evaluation outcomes as to whether the intervention is successful. So it's really this linking that's important between those levels of participation and body structure and function. I mentioned goal formulation. There's been quite a lot of work on goal formulation in areas such as brain injury intervention. And we know that it's not an easy task. We usually have the expectation that we're going to set goals at the very beginning of therapy. But what we know is that it actually needs to happen over time, because we need to establish what are appropriate, achievable and realistic goals for each person we see. Because remember, we're not using a normative framework. The goal is not always typical performance. It's about what is achievable for that person. So in order to do that, we tend to, as I mentioned, gather lots of information about not just the upper limb, but the person's daily life and their supports and attitudes, expectations, what the caregiver thinks. There is a paper that I've put the reference for there, which is where we studied how therapists do this process. And it seemed to be a process where, gathering all of that information, the therapist really understands from the client's point of view what are all of the resources and all of the challenges that they have, both personal, environmental and upper limb related. And then the therapist will tend to negotiate goals and interventions with the family, because it's only at that point where you really understand the situation that you can propose to the client and family what are the goals, that the types of goals that might be realistic and achievable. Because somebody with a very dense upper limb hemiplegia might not be able to play the piano with two hands. Okay, they might need to think in terms of what are the next steps of goal achievement that are realistic for me? What am I aiming for next? So that's where negotiating areas of goal achievement can be very helpful, and you're being informed by your assessment. There are goal setting tools which I think you've heard about already and some of you might use, like the COPM or goal attainment scaling, and those are useful. Currently, I'm doing some research on a new goal setting tool that might be useful for this population of clients, because it's often difficult to predict specifically what the person will achieve until you've done some intervention. So sometimes you need to do some intervention, and that will then feed into the next goal that you propose. But the tool that we're developing is hopefully useful in situations where you can't pinpoint a specific outcome, but you can look at the outcomes that are achieved, and you can gather evidence to show how a goal has been achieved. So more on that as it's developed. So in order to help the person to situate their goal in an achievable or realistic range, these levels of function can be quite useful. So this is a continuum of the levels of function of the upper limb that you can use early on in your assessment to work out where your client might fit. So you can see at the top, it sort of goes from people who might have the least movement control down to the most movement control. And each of your clients might fit anywhere on this continuum. It may be that they don't have much upper limb functional movement at all, and you might be aiming for comfortable positioning of the upper limb to support whole body movement and positioning, so the person is able to maintain their head control when somebody is helping them eat or something like that, or maintain their trunk control because of the position of their upper limbs in a comfortable way to be able to listen and look at what's happening around them, or to to be comfortable when people are doing daily life self-care with them. Then it moves down to use of the limb as a counterweight. So people who can just move their limb and place it on something as a counterweight to stabilise. Then it moves down to use of the arm as a stabiliser or a gross assist. So being able to use your arm more actively to hold something against your body, for instance. Then we move down to use of the hand as a passive stabilizer. So that's where people can place their hand passively around something and maintain the grasp, but they might not be able to open their hand because, as you know, some of our clients might not ever be able to do that, but there is still a level of function that they can achieve. So it's figuring out where they are. And then it moves down to more active grasp, whole hand grasp, digital grasp with the fingers, and then being able to grasp, transport, and do something with that item. So grasping the deodorant to take the lid off and then using the deodorant under your arm. So you can see that being able to do those things, and things like use of a fork, for instance, would fit into that category as well. That comes a fair way down the continuum. So it helps to know, where are we starting? What is the best place to start for this person? And then where might we be going next? It's important to do that so that you're always working on something that's achievable for the person rather than something that is way beyond their upper limb capability at that time and will just cause lots of frustration, lack of motivation, and result in them not being able to achieve their goals. So that can be quite useful to work out early on. So then moving into the key areas of body structure and function to assess, because this is very important. We've talked about that overarching layer of participation and environmental and personal factors, and really understanding the person's daily life and helping them formulate goals that are going to be achievable. But to do that, we need to have a very clear idea of what's happening with their upper limb function. So here are some of the key areas that we can assess. Again, there are some standardized tools that mainly look at the activity level. There's not much that's standardized that helps you with this body structure and function level. So let's break this down. So the areas that I think are most important to assess are range of motion and whether or not the person has a contracture. Again, I'm talking about contracture as shortening of muscle and soft tissue. Okay, so there's been a physiological shortening of the tissue, which usually occurs due to immobilization in a shortened position or a more flexed position over time. Then we'll talk about positive and negative features. And what I mean by that is not positive as in good and negative as in bad, the way we would normally use those terms, but positive is what is excessive, negative is what is missing. We need to think about what is the degree of hypertonicity or spasticity there. So how much of a problem is it? How much do we need to address that aspect particularly? Structural or adaptive change, as I mentioned, contractures, and then analysis of movement patterns, which we won't be able to go into in great depth now, but as I mentioned before, we would be analysing the movement patterns within the context of the task. So starting with positive and negative features or positive and negative symptoms, you can call them either. That terminology is not particularly new. It comes from upper motor neuron syndrome, which has been written about right since the 60s really, and continues to be used today because it's a really good way of being able to talk with between professions around what we're seeing, regardless of what kind of frame of reference we might come from. If you're an occupational therapist, if you're working with physiotherapists, if you're working with doctors and neurologists, we might come from slightly different theoretical backgrounds, but upper motor neuron syndrome gives us a language to talk to each other really clearly about this. So within that context of upper motor neuron syndrome, positive features are excesses or exaggerations of movement, and negative features are deficits or losses in movement. So what is there too much of? What is there not enough of that you're seeing? So positive features, those excesses or exaggerations of movement, and you all know what I mean, where there's too much flexion or there's too much adduction or there's too much shoulder elevation, too much of anything. Those sorts of excesses or exaggerations of movement will be there because of hypertonicity and where the hypertonicity is, and also other hyperactive reflexes, which include spasticity, clonus, which we're used to seeing in the lower limb. So that's that sort of movement, that rhythmic spasming that we see, that you will sometimes see in upper limbs as well. The clasped knife response, so when you try to range the limb and you get a lot of resistance and then that resistance gives way, which has to do with what's happening in our tendons. All those sorts of things will come together to give too much excessive movements or excessive positions that get in the way of the person's positioning and movement. So that's at that reflex level and the hypertonicity level, but also positive features can arise from the adaptations that people make. So if people have difficulty with their forward reach, for instance, and so they use lots of compensatory shoulder elevation and abduction in order to move forward and reach, then that also can be seen as a positive feature, that excessive shoulder elevation and abduction, because it's something that you want to reduce. So it's too much of anything. Then negative features are those losses or deficits in movement. So they will often be there due to muscle weakness. So missing movements, not being able to extend your wrist, not being able to open your fingers, not being able to oppose your thumb, for instance. So it might be there because of muscle weakness or paralysis. And often, if that's the case, we will often see things like hypermobility of the joints or hyperextension. You know, wherever you see hyperextension of any joints, often it's because of a negative feature, because of weakness somewhere. Because in the usual biomechanics of our limb, you know, our muscles that are working in a typical way don't allow that hyperextension to occur. So if you see that hypermobility or hyperextension or loss of architecture of the hand, so flat arches, hypermobile joints, things like that, then you know that there are some negative features there. But again, we can also think of negative features in a functional sense. So the person having reduced endurance or slow initiation of movement or reduced dexterity or learned non-use, where the person is, you know, sort of neglecting that arm or has learned not to use it and is actually able to do more than they're actually doing, but they're not doing it because of learned non-use. So all of those can be seen as negative features. And those features together, positive and negative, result in a lack of movement or lack of movement within restricted ranges. As I mentioned, compensatory movement patterns to work around what is not there and what is excessive. And over time, that then leads to more structural changes like contracture. All of those things together is what we're seeing when we see impaired upper limb function. So just to look at that and see what that looks like visually, if we look at the top left-hand corner, so that person's hand, we can analyse what might be the positive and negative features. So this is a client of mine that I saw post-stroke. So I would say that positive features would be wrist flexion. There's too much of that. Finger PIP flexion, so proximal interphalangeal flexion. There's too much of that. You can also see a positive feature on the middle finger DIP joint, distal interphalangeal joint. So there's too much flexion there. I would say thumb adduction is also a positive feature. Adduction from right down here at the carpo-metacarpal joint. I would say all of those are positive features. There is also too much hyperextension of the MCPs here, but I think that's a negative symptom because there is weakness that's allowing that to happen. So I would say negative features are not enough MCP flexion, because usually when you open your hand, you wouldn't be doing that, okay? So not enough MCP flexion, that's a negative symptom. Not enough PIP extension in order to open her hand because she's trying to open her hand, so that's a negative symptom. Not enough thumb abduction and opposition because that's what she needs to get ready for a grasp. And not enough thumb IP flexion. So see, her thumb is very hyperextended at the IP joint. So all of those would be negative symptoms. So some of the negative symptoms are the opposite of the positive symptoms. So too much PIP flexion is positive, not enough PIP extension is negative. But where you see the difference in position from what you expect to see, so the thumb usually isn't up in the same plane as the hand, it's usually sitting down here, then that's telling you that something is missing. And when you see hyperextension, something is missing. So if we move to the young boy on the right side, he looks like he's doing a pretty good job of grasping the block. However, if you were, so you're comparing this to what you would usually see, right? If you were reaching for something in front of you, you probably wouldn't abduct your shoulder that much. So a positive feature would be shoulder abduction. You probably wouldn't have your elbow that flexed as well. So perhaps elbow flexion and forearm pronation are also positive symptoms. And then when you look at his hand, because of the position of the block, I would expect that my wrist, if I was reaching for that, would be in a neutral position or slightly flexed, but his is extended. So in his case, wrist extension is a positive feature. There's too much wrist extension for the task. And if you look closely, you will be able to see, oh, sorry.
Do you want to
That's okay.
zoom up?
Yeah, no, that's okay. I'll start that sentence again. And if you look closely, you can see the muscle in his wrist, on the extensor surface of his wrist, you can see that being very tight there. So that's his extensor carpi ulnaris that you can see. So we know that there is too much wrist extension for the task. And we're so used to seeing too much wrist flexion. So this is why we have to analyze it individually. I suspect that he's got this shoulder abduction happening because he's trying to place his hand because he's got too much wrist extension. So the shoulder abduction is a compensatory strategy in order to place his hand in the right position. But it's still a positive feature because there's too much of it. Okay, so shoulder abduction, forearm pronation, wrist extension. If you look at his hand and the way he's grasping, it looks okay. But normally, if I was going to grasp something that was that size, I would have all of my fingers at each joint in graded flexion, in sort of a little bit of flexion at all joints. He's sort of doing this. So actually, he probably has too much MCP flexion there and not enough PIP flexion, okay, to get that more graded flexion as you would for an object like that. And because of that, you can see that his DIPs, his little joints at the end of his fingers, are flexing a lot more. So I would say positive features are too much MCP flexion, too much DIP flexion, and a negative symptom is not enough PIP flexion. So you can break it down and see what there's too much of and what there's not enough of. Looking at his thumb, you know, it's okay, but it looks a bit weak. The position looks a bit weak. So therefore, I would say there's maybe not quite enough opposition because you would expect more of a C curve here in the thumb web space when you're holding an object like that. And his thumb is fairly flat. So I would say there's not enough opposition, Okay, that sort of rotational movement to get into that position. And that's why it looks a bit weak. Okay, so maybe you can practice on the other pictures if you like, but just maybe you can see the one on the left, the bottom left side. And you can see here for somebody who's trying to grasp a cup that it looks like, if you imagine what position her shoulder is in, that she's probably got too much external rotation at the shoulder and a little bit too much supination of her forearm. So that is counterintuitive, right? Because we see so much pronation and internal rotation for our clients, but this person has the opposite pattern, and that's why we have to analyse it individually. So positive symptoms, too much external rotation, too much supination, and looking at her hand, too much MCP flexion here, not enough flexion of the other finger joints. So that's a negative symptom, not enough PIP and DIP flexion. And her thumb, too much thumb adduction, so that's a positive symptom, and not enough opposition, so that's a negative symptom. So you can use that system. It takes a little while to process that and get used to what you're seeing, but it's a really nice way of breaking down observationally what is happening during the performance of tasks that are meaningful to the person. And what we do then is we analyse those positive and negative features within the task, and usually that task is relevant to the goals that the person might have. It helps us already with our reasoning process that we can think forward and think that what we want to do is we want to block the positive features and we want to support the negative features with whatever intervention we choose to use. So if we apply that to splinting, for instance, some of the usual splints or the off-the-shelf splints that we use, the standard splint designs that are often used in practice, they often don't, if they are standard and you use them with every client, they don't actually take the positive and negative features into account for each individual. So you can see there on the screen on the left, the person with the what we would call a wrist cock-up splint with the thumb hole there. If that person had any kind of positive or negative symptoms at the thumb, that splint would not do anything about that. And most clients we see have some kind of positive or negative symptoms at the thumb. So that splint design is okay for hand injuries if you're trying to immobilize the wrist, for instance, but it often doesn't work very well for people with hypertonicity. Similarly, on the right there, the resting pan splint that puts the person's thumb into, let me see how I can show you, into this position, so that the thumb is sitting underneath the fingers there, and you do that cutout thumb design and put the thumb underneath. That pattern often doesn't work very well for people who have any kind of symptoms at their thumb. And the fact that the wrist is always in an extended position in that splint doesn't always work either if the person has lots of positive symptoms at the wrist or at the fingers. So sometimes the positioning needs to change. If you look at the picture down the bottom, that's an example of a resting mitt splint, which is more commonly, we use that more commonly for people with hypertonicity because the pattern is different. And as you can see, there is firstly more support around the wrist because you're not using part of the wrist pattern to support the thumb. You know how we pull that underneath? So it's giving more support at the wrist for people who have quite significant positive symptoms at the wrist, a lot of our clients, and it has a different thumb position so that you're able to get more support at the base of the thumb and also support the arches of the hand, which is often what we need to do. I won't go into it in depth, but you can also see in that picture that the positioning of the straps is also really important to deal with the positive and negative features. So usually where there's a positive feature, we're strapping over the joint. Where there's a negative feature, we strap distal to the joint, so you're creating flexion. So we actually even individualize where we're putting the straps based on what the positive and negative symptoms are. So this is an indication that some of those standard splint designs might not be relevant for people with hypertonicity. And this next slide just gives you a few more examples of that. So in each of these situations, so we have 3 pairs of pictures. So for instance, this person up the top here, that's the picture you saw before. And this splinting system here is just addressing all of the positive and negative features that we identified. Okay, so this is a combination of a hand-based splint that is positioning the thumb in opposition and supporting the arch and blocking that MCP flexion. And it's in combination with a pronation strap that's made of neoprene that anchors onto this hand-based splint and winds around the forearm to bring her into pronation for tasks that need that positioning. So all the splinting is doing is breaking down the positive and negative features, blocking the positive, supporting the negative, or supporting what's not there. The same with this young man over on the right here, where you can see the splint is blocking the positive symptom of wrist flexion, and it's blocking the positive symptom of MCP flexion of these fingers, but it's supporting the flexion of the MCPs of these fingers, because you see each of these knuckles is doing different things, and it's only because we've broken them down that we know what to do about it. And you can see a very interesting thing in this photo is that blocking the wrist flexion and correcting the MCP flexion, and you can see the splint is also positioning his thumb, so it's blocking thumb adduction and positioning him in an opposed position. But you can see that changing the position of the wrist and the MCPs has reduced the swan necking in his fingers. So you can see here where this swan necking was very prominent in this finger, it's now greatly reduced, and he's got much more chance of grasping. So that is like a secondary problem from this primary problem. So often the wrist and the MCPs will be the primary problem, and if you change that, then this secondary issue will also change. And it's the same for the thumb. So if you change the primary problem of thumb adduction, then the secondary problem of what happens more distally can sometimes change. And here's another example here of this person had more associated hypertonicity that brought his thumb into his palm when he was trying to grasp. And so all he really needed was a thumb post because his control of his wrist was fine. So if you didn't think about that, you might give the man a wrist splint as well, but he doesn't need one because his wrist control is fine. So breaking that down really helps us to design whatever we're doing, in this case splints, but it might be where the Botox goes, or it might be what you do with casting, or it might be what kind of surgery is going to be relevant. So breaking down into those positive and negative features can help that decision-making process in a really specific way for the individual. Okay, then we move on to thinking about assessing hypertonicity, Hipertonía. I like saying that word. So hypertonicity, the concept of hypertonicity is not very well understood. Sometimes we think about hypertonicity and spasticity as the same things, but they're not. Clinically, hypertonicity is really what we feel. So it's that increased resistance to movement that we feel as stiffness when we're trying to move the person's limb or when they're trying to move their limb. but it's made up of different components. It's made up of a neural component and it's made up of a non-neural component. So there's we could talk about this in lots of depth, but just as an overview, the neural component is that hyperactivity of the stretch reflex, and that's really the spasticity. So the spasticity is the neural component, and this is the hyperactive stretch reflex firing off over and over and over and over. Yep. And then the non-neural component is the actual changes to the physiology, to the structure of the muscles and tendons and ligaments and cartilage, because they're not able to move in a usual way through their usual range. Everyone we see with hypertonicity has some level of immobilization. Even if they can move, they don't move in a typical way, and they don't move as much as you or I would. So there's always some degree of immobilization that's imposed. And because of that, what happens is that there are structural changes that happen right at that soft tissue level. So for instance, the muscle fibers are more in an overlapped position because the muscle's contracted more of the time. And it's harder for those bonds, those chemical bonds that make the muscle strong, to break down all the time while the muscle is stretching and contracting and stretching and contracting. So the muscle becomes more sticky, less pliable. It's stiffer at the cellular level. And there are more sort of issues with the muscle and the soft tissue stretching and being more pliable again. So that stiffness is also adding to the resistance that we feel. It's not just the neural component. And the different clients that we see will have differing levels of spasticity, the neural component, and the stiffness, the non-neural component. And we need to figure out how much of each of those is part of the resistance that we're seeing, because we will use different interventions if there's lots of spasticity, and we'll use a different sort of intervention if there's more stiffness. So we want to figure out, are the influences on the limb more spasticity or more stiffness, and maybe contracture, because that stiffness then will lead to contracture. So some of our assessment we can use to differentiate between, does that person have more spasticity, or do they have more stiffness, and is the limitation in movement due to contracture? We can use a couple of different tools to help us with this. There is a lot of work going on with more objective ways of measuring hypertonicity and spasticity, using robotics and using other more machine-driven ways of standardizing the way we're moving the limb. They are not really at a point of being used in clinical practice yet. They're not easily accessible to the clinician in everyday practice. So here in Australia, most people use some of these scales in the clinical setting in order to measure this. So we have two scales that are often used. There are more than two, but we'll just talk about these: the modified Tardieu scale and the modified Ashworth scale. So firstly, the modified Ashworth scale of muscle spasticity is what it's called, but it's actually measuring hypertonicity, even though it's called the scale of spasticity. You can see all of the range of the ratings there and how they progress. So it goes from 1 is where you've got slight increase in muscle tone while you're moving the limb, and there's minimal resistance at the end of the range. So that's someone with not very much hypertonicity. When you move down, say, to 2, you've got a more marked increase in that resistance as you're moving the limb through most of the range. So you can feel that right from the beginning, but the affected part is still easily moved. And then it moves down to 3 and 4, where there's lots more resistance that you're feeling. So most people will use this as a measure of how much hypertonicity is there in particular muscle groups. It's important if you use these kinds of scales that maybe the same person is doing the ranging each time, so that's consistent within your centre, because there is some difference between inter-rater reliability of using these sorts of scales. But if you use it as the same clinician in each setting, then you'll be able to feel changes as you do interventions. So that's the modified Ashworth scale. So that tells you how much resistance you can feel, and it gives a little bit of information as to where there might be a catch. So a catch is where the stretch reflex comes in. But it doesn't give a lot of information about spasticity. So often we would add the Tardieu scale to the Ashworth scale and do both of those. The Tardieu scale also has the ratings like the Ashworth scale does, but it's not as sensitive to change. The part of the Tardieu that's really helpful is the part that measures spasticity. So this is where you take two measures of passive range, and we call those R2 and R1. So R2 is the passive range that you can measure with a goniometer by stretching the limb and doing passive range slowly. So slow, steady movement, a slow velocity. And you know then that you're not engaging the stretch reflex, right? You're doing it nice and slowly. Hold, wait, go a bit further. Hold, wait, go a bit further. That's R2. And then R1 is the angle where you can feel the catch when you move the limb fast, so quickly. So first of all, you're doing slow stretch, which is R2, and then the next one is quick. So with that quick movement, where the catch first appears, you can measure that angle. You can do it with the wrist and fingers as well. So measuring quickly, quick movement, and where is that catch? So that's R1. So if you can take that, it's quite quick to do. So when you do those two measures, then you can do the calculation of R2 minus R1. So in this case, for instance, if we're doing this process with the biceps, so doing elbow extension, R2, we might be able to get to 160 degrees. But then when we move fast, the catch might be at 130 degrees. So the difference between R2 and R1 is 30 degrees, and that's the spasticity angle, okay? So you've done your Ashworth scale and you've said, okay, maybe Ashworth scale of 2, so there's moderate hypertonicity when I'm moving, and then you're going to do the Tardieu and figure out that you've got a spasticity angle of 30 degrees. Now the relevance of that spasticity angle is because it helps you to work out if the person has a contracture or if they have hypertonicity that's limiting their range. So with the clients we have where they can't move within their full range, you can't stretch them out as far as is typical range, we often don't know, is that because of hypertonicity or is it because of contracture? The spasticity angle will help you figure that out. So if the difference between R1 and R2 is small, so 20 degrees, 10 degrees or 20 degrees or 30 degrees, it's more likely that that limitation in range is a contracture because the spasticity isn't coming in until later in the range, okay? You can't feel the resistance very early on. You can only feel it a long way through the range, okay? So it's more likely to be contracture if the spasticity angle is small. If the spasticity angle is large, that means the catch comes in really early in the range, okay? So here's the catch, but I can keep going and it's lots of resistance, but I can go a fair way. If that's the case, the spasticity angle is large, then it's more likely that the limitation you're feeling is because of hypertonicity. Why is that important? Because if it's contracture, you're probably going to need to do something like casting or maybe surgery in order to change the contracture. If it's hypertonicity, you might do casting, but the person might also respond to splinting or to Botox, for instance. So different interventions might be relevant depending on that. I've seen many clients who have had lots of Botox injections, but they still get contractures and they still have limited range because the problem has been a contracture and not just the spasticity. So that can help you to work out which is contributing more. Other things like the end feel of the joint. So if you range the limb and the end feel is quite hard and quite sudden, that might indicate it's a contracture. Whereas if it's a more bouncy end feel, so you're ranging the limb and you think, I think I could go further, but it's really hard, lots of resistance, then that might be that it's more about hypertonicity. Sometimes you don't know whether it's a contracture or just hypertonicity until you do the intervention. Because when we do things like casting for people, if you have quite limited range and you put a cast on for a week and then the person has nearly full range, and sometimes that happens, then you know that was probably hypertonicity, because we probably wouldn't be able to lengthen the contraction that quickly. It would probably take a couple more weeks. So the rule of thumb here is that if the person's passive range is limited anywhere, then you need to suspect a contracture. But these kinds of assessments can help you work out whether it's more hypertonicity and particularly spasticity, or if it's a contracture that you're dealing with. That's a usual part of assessment. Another important part of assessment that we use for people with hypertonicity is making sure that we evaluate the wrist and the fingers together rather than separately. And this goes back to what I mentioned earlier about the position of splints, the position of casts and things like that, because we are often used to making splints, for instance, or encouraging the person to have the same position, the usual resting position or the usual functional position with the wrist and extension. And that doesn't always work for people with hypertonicity, because most people, many people, will have positive and or negative symptoms in their extrinsic finger muscles, usually their finger flexors, which cross over the finger joints and they cross over the wrist as well. So anything you do with the wrist is going to affect the fingers, which is why we have, for instance, people with spinal injury use a tenodesis grip and that sort of thing, because whatever you do with the wrist position affects the fingers, particularly if there's hypertonicity in the finger flexors. So it's really important during assessment that we evaluate the effect of the wrist position on grasp and on the fingers in general. And what that means is that when you're thinking about ranging, if the person has wrist flexion, then we need to do two measures. We need to do wrist extension with their fingers flexed, so that you're just extending their wrist without worrying about stretching out their fingers. And that will tell you if you have hypertonicity or contracture in the wrist flexors, because you're letting the finger flexors go, okay? The finger flexors aren't being stretched. So you're taking them out of the equation and you're just measuring the wrist flexors. But if you just do that and you go, okay, great, they've got good wrist range, I'll make them a splint in this position, it might not work. Because the second thing you need to do is to do wrist extension with fingers extended. And when I say extended, I mean, in the resting position, in that sort of think about the biomechanics of the hand and protect the biomechanics. So that nice curved position of the hand, wrist extension with fingers extended. That is stretching the wrist flexors and the finger flexors. So quite often there is a different range that you get when you do this and when you do this. Often you might be able to get quite good range when the fingers are flexed, but when you do this, you might not even get to neutral. You might still be in flexion. So there might be a big difference between this and this in terms of the range that you can get. What this measurement tells you, wrist extension with fingers extended, is that there is hypertonicity or contracture in the finger flexors. So then what you need to do is adjust the person's wrist to the position where they can open their hand, or the position where you can, if they can't use their hand very well, to the position where you can maintain a relaxed position of the fingers. Because if you hold their wrist in extension, as we might do in a functional splint, they might not be able to open their fingers, so they might really struggle. If you bring their wrist down a little bit, it might be easier. If you bring their wrist down a little bit more, they might be able to open their hand. You adjust the wrist position to where they can open their hand, or if it's a more passive situation, then adjust their wrist position to where you can maintain a gentle curve of the fingers. That is the wrist position where you will be making a splint or making a cast, okay? Because that's where they can use their fingers, okay? So it's really important to look at that individually for each person. Because what we're trying to do with anything that we're doing in intervention is use sub-maximal positioning rather than maximal positioning. If you stretch as far as you can stretch, that favours elasticity of the hypertonic muscles. So if you were to make a splint for somebody in that position, it's very uncomfortable. It doesn't protect the biomechanics of the limb, but also when you take it off, it will bounce back because it will favour elasticity of the muscles because it's maximum stretch. If you stretch in a gentle way and it's submaximal, then that favours plasticity of the muscle so that it will be able to maintain that more lengthened position more easily. So what that means is that it's easy to work out submaximal positioning of the elbow because you can say, okay, I can get that person to 160, we will position them in 150 and take off 10 degrees. But with the wrist and hand, you need to go through that process that we just talked about. And what that means is it's often not appropriate to split the wrist in extension for someone with hypertonicity. You need to figure out if you need to drop the wrist down in order to maintain the fingers. So as an example, you can see in this picture on the left, this young man has a splint that is in the normal resting position with the wrist in slight extension, and you can see what's happening to his fingers. So that is too much maximum stretch of the finger flexors, and so what's happening is he's getting that hyperextension and clawing into the splint. So that's not going to help him much at all. On the right, you can see that the splint has just been dropped down a little bit at the wrist. If you can see, that's just in slight flexion, not very much flexion at all, just slight flexion, and now his fingers are relaxed. So that was enough to be able to achieve sub-maximal stretch of the finger flexors. So it's important to go through that process with every person. If you need to go all the way down here for the fingers to be relaxed or for the person to be able to open their hand, that means your finger flexors are very, very, very hypertonic or very contracted, and you probably need to do something else like Botox or casting, maybe surgery, but I'd try Botox or casting first in order to stretch out those muscles and get into a better position, okay? So if you need to really compromise that a lot, it's telling you that you need a different intervention. Okay, so there's lots of reasoning. There's lots of reasoning, as we can see from those aspects of assessment that we talked about, and it's very individualised. And we know from some of the research that we've done that hypertonicity management is very complex, and it's quite difficult to develop expertise. It's not necessarily the case from the research we've done that the longer you practice, the more expert you become in this area of practice. It really is the only thing that was associated in our research with expertise was specific training of this sort of nature that helped you to gain expertise. So in areas of practice like that, where there is a lot of complex decision-making aids can be really useful. So these are algorithms or flow charts or structures, frameworks that help to organise and stratify clients according to their characteristics and identify relevant characteristics for each group that you can then link to the interventions that are going to work. So decision-making aids have been used increasingly in neurology. One of my PhD students has recently done a systematic review of different decision-making aids and found that in upper limb neuro rehab, there was about maybe 8 or 9 of them, but maybe 4 of them were had some research done on them. And one of those is the one that I'm going to tell you about today, the hypertonicity intervention planning model, which is my decision-making aid for upper limb neuro rehab. So the hypertonicity intervention planning model was developed and grounded in practice-based knowledge from seeing clients in practice. And then we've had some research to validate the framework more. So some of the points there just tell you about some of the research that we've done. So what we've found is when we've trained occupational therapists in the HIPM, HIPM, when we've trained them in the HIPM, novice occupational therapists, so early year people who are new graduate therapists, their decision making became more flexible, and they were able to link information more from the assessment to the intervention choice, which is what's really important, because often we do all this assessment and then we think, well, what do we do with that information? The assessment and the intervention really has to link. So novices' decision-making became more linked and more flexible, and even expert therapists, when they were trained in this model, increased their capacity for collaborating with the client more and making more collaborative decisions, and also using more individualised or upper limb focused intervention. So their intervention choice was less similar across different clients. It was distinguished more and individualised more across clients, even for expert therapists. And we've also done some research with the HIPM around casting as an intervention and resting splints to see if the groups that we have aligned with those interventions actually work. So if you provide intervention in the way that the HIPM recommends to clients with these particular characteristics, and you can see they're called Group 2B, Group 3, Group 2A, if you align it like that, does it work? And that splinting study there showed that if you use resting splints for clients in that particular group that the HIPM says they will work for, then it worked for them, because the HIPM is saying that resting splints aren't going to be the optimal intervention for everybody, but for these people in group 2A who have moderate hypertonicity and they don't have contracture, then that's a good first intervention option to use. So that's how that research is progressing. So just to introduce you then to the HIPM, it has these different components to it. So we've just talked about the assessment, and then it groups the upper limb characteristics along this continuum. And then we form clinical aims, consider personal environmental factors, negotiate goals that fit with what the person might be able to do, and then the intervention choice connects with that. So just to work through that, as we've just worked through, this is what your assessment has identified. It's identified the positive and negative features and the severity of those, the extent to which the hypertonicity is affecting the limb, whether there's contracture and where it is, and how much controlled movement is available. And that allows us to place the client along the continuum. I have a full version of the HIPM with the whole continuum that's a little bit more complex, but we're translating that for you now so that we can put that up on the website. Today, I'll work through the different aspects of the HIPM and I'll show you a simplified version on the screen. So, firstly, if we think about how we're classifying people along this continuum, the first aspect is in terms of upper limb impairment. So that's the body structure aspect. So you can see here is that we have clients divided into HIPAM 1, 2A, 2B, and 3. For people in each of these categories, you can see we've defined how much hypertonicity they might have at rest and on activity using the modified Ashworth scale. So that's the MAS, M-A-S. And also the degree of spasticity that might be there using the modified Tardieu scale or the MTS. We've also talked about their muscle strength, and we've also talked about whether or not there might be contracture or organic contracture. So just to summarise that, you can read it in depth, but what you can see there is that people in HIPAM 1 usually don't have very much hypertonicity at rest. So these are people who might be in a normal resting position at rest. And you can only see the impact of their hypertonicity once they start to move. And once they start to move, you start to see a little bit of joint instability, maybe a little bit of hyperextension of their this joint of their thumb. Or you might see a little bit of thumb adduction or wrist flexion or ulnar deviation. So mild malalignment from positive and negative symptoms that comes when they're moving. And often they have quite good muscle strength and they're able to move quite well, okay? But there is a mild influence of hypertonicity and a mild influence also of weakness that's causing just mild malalignment. But these are people who are usually quite functional, so that mild malalignment really makes it difficult for them to do all the things they want to do. People in 2A have more moderate hypertonicity at rest, so they tend to be more malaligned in their positions. They might have a bit more sort of moderate spasticity, but they still are able to move. They don't have a lot of muscle weakness. So you'll see on the next slide when we get to that what that looks like. People in 2B have more moderate to severe hypertonicity. So you've measured more hypertonicity at rest. So a mass of coming up to sort of 2 or 2 plus to 3. And then they also, at level 2B, might have some organic contracture. So these people will tend to have more difference between their functioning in different muscles. So they might have some muscles that are paralysed as well. So the muscle strength ranges from 0 to 3, where some muscles are working and some muscles really aren't working actively at all. And then people in HIPAM group 3 have very severe hypertonicity, very severe posturing at rest, lots of spasticity usually, and severe organic contracture. And the contracture has progressed from just muscle and soft tissue to maybe joint involvement as well. So there might be a bony block to movement because the joint is contracted itself. So that's the sort of level of hypertonicity and contracture that increases as you go from left to right. And then if we look at upper limb function, and you can see the pictures down the bottom that can help you a little bit, if we can see those. They help a little bit to sort of give you an image of that. So people in HIPAM 1, their main functional issues are they're able to move, they've got quite good proximal control, but they might have some difficulty with fine manipulation and dexterity and being able to sort of manipulate items within their hand. So they can get a digital grasp, but it's a little bit clumsy or it's a little bit weak, or they can't quite get thumb opposition to get a fine grasp when they're doing finer movements. So their prehension is reduced, and maybe the speed and dexterity of their movement and endurance is reduced. For people in 2A, they're able to do, they've got also reasonable control proximally of reaching, but they have much more patterned movements. So the malalignment of their joints is more significant, and that means that they can grasp, often with their fingers, but they will have reduced reliability of grasp. So the grasp isn't particularly reliable and isn't particularly efficient. So they tend to make lots of mistakes and drop items and can only use their function for some tasks, but not anything that's particularly fine. and it's quite effortful because they're in quite malaligned positions. People in group 3 have much more people in group 2B have much more limited active proximal movement. So it's much harder for them to reach, and they'll often have much more compensatory movements. So these people have only gross use of the upper limb, either whole arm stabilizer use, or they can sometimes get gross grasp with their hand, but it's difficult for them to put reach and grasp together. So they might have their hand quite close to their body and be able to grasp things here, or they might be able to use their whole upper limb to tuck things under their arm, for instance, but it's very gross movement and gross function. And then people in HIPM 3 generally have no upper limb movement at all. So they might have little flickers of movement, but really not any voluntary control. And you can see the picture there. So they obviously have lots and lots of positive symptoms and lots of negative symptoms, and lots of weakness. So there's not very much active movement. So if you can classify people in that way, then the next thing that you can do, and I should say also, is that often people don't neatly fit into one category. Sometimes people will have some characteristics of one group and emerging characteristics of another group, because as people progress post-injury, they move across the groups. So someone who starts as 2A could progress to 2B, or someone in 2B could progress to 3 as they progress post-injury, or if it's a child, as they get older, if they don't have intervention. So if you know where people are starting, you can come up with clinical aims that correspond to those characteristics. So this is where you're really matching your assessment and your goal setting. So clinical aims, we're thinking of clinical aims at the level of the limb, okay? And as I mentioned earlier, we match our clinical aims with our functional daily life goals. So our clinical aims might be for people in group 1, improving accuracy and patterns of prehension. And so that coordination and quality of movement and strength and endurance. So it's those more sort of functional, active use of the limb that you're mainly focusing on. And you don't really need to do a lot about reducing hypertonicity at rest, because there's not very much hypertonicity at rest at all. You might need to change the positioning of particular joints during function, because that's when the hypertonicity impacts on them. For people in 2A, it's really important that you improve their positioning for functioning, because their positioning for functioning is really getting in the way of reliable, active and accurate use of the limb. So improving their positioning for functioning, so improving their wrist position, improving their thumb position, improving, their position of their MCPs so that they can work more effectively on grasp, that is a priority for them, because that's what's getting in the way most. Reducing their hypertonicity can often be an aim as well, but it's a secondary aim, because these people have reasonably good muscle strength, remember. So even though they've got hypertonicity, they're still able to move quite well. It's just that they're in very adapted patterns. So you might still need to do something about their hypertonicity, but it's not quite the first aim. Whereas for people in group 2B, they have lots of hypertonicity, they have organic contracture, so you need to do something about that first before you're able to then position them for taking advantage of the small amount of function that they have for gross grasp or something like that. So you really have to do something about that first. All of these are very important, because it's going to tell you what is the first part of my intervention I need to do. And then people in group 3, again, you're going to reduce the spasticity or hypertonicity and organic contracture first, because that's a big factor for them. But you can see the difference between 2B and 3 is that the reason why you're reducing the spasticity and hypertonicity, and the reason why you're lengthening contractures for people in 2B, is so that you can improve their positioning for function, so they can use that limb in some way as a stabilizer. Whereas for people in group 3, they're not going to be able to use their limb actively. So the reason why you're changing the hypertonicity and the organic contracture is so that you're improving their positioning for comfort and care. So ease of caregiving for the caregiver, comfort for that person in being able to participate in daily life by being alert and being positioned well so that other people can interact with them, and so that they don't have problems like hygiene management if they're in very contracted positions where skin breaks down in their palm or in their elbow. I've seen many people in group 3 that is the case for if they don't have some kind of intervention to change those positive features in order to change their positioning. So you're doing the same things, but you're doing it for a different reason. And then, as I mentioned earlier, we're then negotiating daily life goals. So daily life goals are, as we talked about before, those goals that are about participation in day-to-day tasks. We mentioned earlier, so we're coming back to what we started with, that we are going to negotiate those with the person and their caregivers based on the level of function that they're capable of, so that it's realistic and achievable. And the key thing at this point, you've got all that assessment information, you've figured out where the person is on the HIPM, you know what are the main clinical aims that you're seeking to change. You have to link those clinical aims to the goals, to the daily life goals. So there's clinical aims for changing the upper limb need to be thought about in relation to their daily life goal. So for instance, if you have someone who's in group 3 who can't move, where really you're looking at that care and comfort sort of goals, an example goal might be to increase the ease of dressing and reduce the time and energy for the caregiver when they're dressing the person. And that might be really important for the quality of life for both the person and the caregiver, right? What you need to do is link that to your clinical aims. So here I have 2 levels of clinical aims. To achieve that goal for that person, and think about the person in the picture that had the significant wrist and elbow flexion perhaps. What you want to do is reposition the elbow and the wrist into a less flexed position and increase the ease of passive movement. And the way you're going to do that, based on your assessment information for that person, you figured out that they've got contractures and severe hypertonicity in the elbow flexors and in the wrist and finger flexors. And so you want to lengthen those contractures and reduce that hypertonicity. Most likely, you do that using something like casting. If that was very difficult for you to use, you might then use surgery if that was available to you. But casting would probably be your first option in that situation. So it's only by linking the goals and the clinical aims that then you know, okay, this is what I need to do. This is the intervention that will achieve those clinical aims and contribute to achievement of the goal. So that last phase is the intervention choice. And so in the HIPM, interventions are chosen that address the clinical aims, meet the needs of the person and the family or the caregivers, and achieve those negotiated goals that you've worked out together that are the next steps for the person. So in the HIPM, different intervention techniques might be indicated depending on what are the primary impairments. So all those things we talked about before, working out, is this mainly hypertonicity or is it contracture? Do they have active use of these muscle groups or don't they have active use? What are the positive and negative symptoms telling me? What is the Ashworth scale and the Target scale telling me? Once you've figured that out, you figured out what is the main factor or the first factors that are impacting. So is it contracture? Is there contracture present, but it's not really affecting their movement so much, so they've only got maybe 20 degrees contracture at the end of the range and they don't really need to have full range for any of the activities they're doing? Or alternatively, is that contracture the main thing that's limiting their movement or care because it's quite significant contracture? And the person needs to be able to stabilize on their forearms with their elbows at 90 degrees in order to get head control. Or they need to be able to, the caregiver needs to be able to range their limb in order to dress or manage hygiene, for instance. So what are the main factors here? If we think about that in relation to people in group 2A, and those are the people who can move and they can use their arm okay, but they're in quite adapted malaligned positions because of the degree of their positive and negative symptoms. So for those people, if they have, malalignment when they're moving and they're going into these quite unusual positions that are making it difficult to get a good grasp and release and so forth, if that's the main issue, and then at rest they're a little bit malaligned but it's not really a problem so much, they're not in this kind of position or in this kind of position, if that's the case, then it might be that a functional splint to position them during movement is what they need, and strength and movement training to be able to get better at those active functions in daily life. However, if the same person is malaligned when they're moving and they're also malaligned at rest, and you can see that that's going to lead to contractures and further problems because of the fact that they're in that shortened position and they're not moving out of that as often, then they probably need a resting splint as well. So remember, these people in 2A, they only have sort of moderate tone, moderate hypertonicity, and you can probably stretch them out of it. But if they're actually at rest in those malaligned positions, then they need a resting splint, as well as a functional splint for when they're moving in conjunction with the movement and strength training. So this is, as I promised, a fairly simplified version of the HIPM, and we will give you the more complicated version. But what you can see here, and this version has group 2A and 2B together, what you can see here is that the interventions down the bottom are kind of aligned with where you might start for each group. So for instance, for people in group 1, where there's not a lot of hypertonicity and the issues are mainly around their manipulation and dexterity and so forth and finer grasps, you're probably going to start with strength and movement training only. You might add a functional splint, as you can see in the picture, if you're doing strength and movement training, but they're still not quite, getting the specific improvement you're looking for because of some of that malalignment during activity, then you might add a functional splint to that. For people in group 2, for 2A, you might be starting with splints. You probably won't just do strength and movement training for people who are in group 2A because they are quite malaligned. So they need something to change their position for function and they need it quick. So you're probably going to start with splints, also with strength and movement training. You wouldn't use functional splints without strength and movement training. They might also need a resting splint, as I said, if they're malaligned at rest. For people in group 2, remember they've got lots of hypertonicity and they've got some contracture as well. So these people in group 2B are more likely to start with things like casting, because if they've got contracture, splints won't change that. If you want to lengthen a contracture, splints will not lengthen it. Casting often will. And because they've got lots of hypertonicity and potentially spasticity, botulinum toxin, Botox injection might be quite important as well in order to remember the clinical aim. One of the first clinical aims for people in 2B was about reducing the hypertonicity, lengthening the contracture. So you don't want to stay down here with strength and movement training for a long time with these people in group 2B because their contractures will just continue to develop. And then for people in group 3 who have no movement and lots of posturing and lots of hypertonicity and lots of contractures, you're probably going to start with these options. So again, the casting, the Botox, the surgery. You can see in these situations, you're still using splints to maintain the person. So you wouldn't do all of those things and then not make a splint, because then quite likely those positive symptoms will come back again. it won't maintain by itself. So really, all of these interventions might be relevant for any of the people in any of these groups, but you're targeting them in quite an intentional way, and you're starting from where the person's at as the least invasive intervention that's needed to address their particular clinical aims. So you can read about the more complex version of the HIPM when we put that up on the website, and you can ask me any questions that you need to about that. Okay, so just to finish off then, I thought that you might like to know, because I mentioned strength and movement training, I thought you might just like a little bit of information about what is most evidence-based in terms of interventions being used. I know that you're using some of these interventions over in South America as well. And also, I just wanted to just illustrate when you might move on from one type of intervention to the next, so that we're thinking about how these interventions blend together. So hopefully that's sort of clear by now, that we don't use one intervention on its own for anyone with hypertonicity. It's always a tailored combination of interventions that's specifically addressing the symptoms and the characteristics that that person has in the context of their life and their day-to-day goals. So thinking about strength and movement training, the most evidence-based interventions, and there is evidence for all of these interventions. So there's not research that's telling us it's important to use one of these more than another, but that it's reasonable and recommended to choose a combination of these interventions in different circumstances. I know you're familiar with constraint-induced movement therapy, and bimanual training, often using those two interventions together is recommended, and some of the research that's looked at those in conjunction with each other has shown very good results. Functional electrical stimulation, you might be familiar with as well. Generally, that's going to be more useful for people who are able to contract the muscle beforehand, rather than those people who are showing no flickers of muscle contraction. Mental imagery, mirror therapy, and intensive task practice. So any of those interventions, we could do a whole presentation on. We could do a 2-day presentation on any of those interventions. But just so that you know that people are choosing combinations of those together, and there's nothing to say in the research that any one of those is better than another. It's really about what is going to be most applicable to each person given their difficulties. So we know that they might be best in combination. When you analyse what those strength and movement training interventions are doing, and think about it in the context of what we talked about with positive and negative features, the role of hypertonicity and contracture, it really appears that using those strength and movement interventions by themselves, without anything else, without any splinting, casting, Botox, surgery, is probably most relevant to people who don't have severe hypertonicity. So those people in HIPM 1 or HIPM 2A groups, so milder hypertonicity and reasonable control of movement, but with malalignment and so forth. And even for those people, these interventions might be more effective if hypertonicity is reduced first. So even when I see a child, for instance, who's in HIPM group 1, who has just mild hypertonicity, often I will, because it's difficult to splint younger children and often they don't like to have splints on, I might do some casting, some inhibitive casting for them for a couple of weeks before then working on the movements through play and through other interventions. So this hasn't quite made it into some of the research yet, but if you're doing things like constraint-induced movement therapy with someone and they've got quite a lot of hypertonicity, obviously constraint is going to be very frustrating for them if they don't have much capacity to use their arm, use their limb. So you need to think about them having at least some control of movement to use constraint, and you might get better results if you do something like casting or Botox first before you use a constraint. So they've got more opportunity and more capacity for using their limb actively once the hypertonicity is reduced. The other thing to think about is that I guess where research is with strength and movement training is thinking about dosage, or how much intervention is required and how often, and what is the minimum that we can do. So lots of the research is looking at things like day camps, particularly for children, where you're doing these interventions really intensively. But we're very aware that's not always practically feasible, and nor do services have the funding to provide that level of therapy. So the research is looking at, can we get the same results if we do it in a less intensive way? And so if you're thinking about strength and movement training interventions and all of those we just talked about, remember that they're not going to do everything. Remember that if you're doing those retraining activities and still the person is going into malaligned positions at rest or less than optimal positions during activity, so they're not getting mechanical advantage because their wrist is in a slightly on the deviated position, or their thumb is slightly adducted, or they're just getting an inferior pincer grasp and they're not sort of getting a good solid reliable whole hand grasp, that kind of thing. So you're still getting that change, you need to think about a splint, probably a functional splint. If they're still in positions of deformity at rest, if you're doing lots of ranging, passive ranging, for instance, and they're still in malaligned positions at rest, then they'll need a resting splint. So don't wait to do that, because then those are the people who'll be developing the contractures. So that's your rule of thumb. If those things are still happening, then you need to add splinting onto the equation. And then if there's still issues, you might need to add casting or Botox onto the equation. And then you might need to look at surgery as well. The main thing is that you're able to have a range of options at your disposal that you can offer in a individualized, tailored way for each individual person, and offer those in the order that they're going to most likely address the aims, rather than just choosing an intervention because that's what you do with people with hypertonicity. It's very, very tailored. And then, as I said, maybe if you add splinting isn't enough. Do you remember this lady who we saw earlier? I'm not sure if you can quite see her picture, that second picture of hers there. But you can see that that was the picture that we looked at, her positive and negative features and the way she was grasping. The first picture shows you her the range that she had to begin with. So this is wrist extension with fingers extended. That's as far as we could get her. And this was her grasp down here. She had some casting, so splinting didn't work for her. She'd had splinting before we saw her, but she's someone who's in group 2B. So we already know splinting isn't going to do everything for her. So she had only, I think, 2 casts. And then you can see over here that this picture shows her opening her hand. So you can see that there's less MCP hyperextension, there is less PIP flexion, her thumb is starting to be in a better position. She's still going to need a functional splint for her thumb to bring her thumb around. But that's starting to change the pattern of movement, but that needed casting to get her to the point where we could use splints and retraining activities again. And you can see that her range after the casting, now she has more significant wrist extension than she had at the beginning where we couldn't quite get her to neutral. So that was through 2 weeks of casting intervention. So that's just by way of illustrating when you might need to move on and move through the interventions. And there's a note there that if you're moving through those interventions using casting or using Botox or needing to use surgery if there's quite intractable spasticity or joint changes, you would then come back to using splinting for maintenance after all of those interventions, and probably strength and movement training as well if the person is able to move. So if they're anybody other than in group 3. Okay, so I think that we've come to the end of the presentation. I know that was a lot of information and it was quite in depth. Those are the key concepts that I think are good to start with, but the kind of things that are probably good to practice in relation to assessment. So I know when I first understood concepts like positive and negative symptoms, it took me quite a while and quite a bit of practice in looking at that with different clients to make that automatic. So some of those that I've presented today are the building blocks to bring together into your clinical reasoning to really make individualized intervention decisions. So thank you all very much, and let's have some questions and discussions.
Muchas gracias.
Muchas gracias, Jenny, por tremenda presentación de la profe Jody Copley. De verdad interesante la forma de razonamiento clínico, que yo creo que es un aporte sobre todo para los colegas de Latinoamérica. Ahora vamos a las preguntas, ¿cierto, Jenny? Que los colegas vayan levantando la mano los que quieran preguntar directamente.
Y, oye, y le vamos a dar la bienvenida a Jody, que está conectada. La pantalla que ven no es una foto, es ella que está ahí para responder las preguntas. Así que, Jody, they were just saying, I was just saying that you are here, and Leonardo, that is the president of the Chilean Association, said that it was so interesting to listen your presentation, and it will be so useful for the Latin American community.
Gracias, Leonardo. Jenny, can you please tell people, I'm very sorry that the presentation was so long, but it's difficult to package up this information in a shorter form, yeah?
Yeah. Pido disculpas porque la presentación fue tan larga, pero es muy difícil hacer toda esta información, meterla en una presentación más corta. Así es que eso, las personas que quieran hacer comentarios, no sé, Seba o Leo, para que las conectemos en YouTube.
Yo escribiendo en español en este minuto, Jenny.
¿Hay alguien escribiendo?
Jody, escribiendo en español.
Oh, qué lindo.
Oh, I am practicing.
You're beautiful, Jody.
Por lo menos desde YouTube. Hi Jody, how are you? Nice to see you again. Solamente no hay preguntas hasta el momento, solamente felicitando a Jody por su presentación, y bueno, también que lo explicó de muy buena forma, muy buena información, y que también da énfasis a la importancia que le da a Jody en la presentación sobre cómo posicionar al pulgar al momento de llevar a cabo o confeccionar una férula. Simplemente eso por el momento.
¿Era un comentario o una pregunta?
Un comentario, sí.
Jody, Sebastian was describing a comment that said that it was so useful, so clear, so much interesting information, and she found so interesting the tips you gave in terms of positioning the thumb.
Yes, the thumb is very difficult. And I think that what we get used to doing, because a lot of our clients have issues with their thumb adduction and often up in the same plane as the hand, we forget the need to do this kind of positioning and to have, because at the basis, the normal resting and normal functioning positions of the hand are in our mind. And then we have to superimpose the positive and negative symptoms on top of that. So even if somebody has a very tight thumb, we have to be careful not to just do this when we make something, because it won't sustain, and often you'll get subluxation of the thumb joint. And so I always teach for my students, I always say abduct and circumduct, abduct and circumduct. And halfway round is your resting position, and all the way around is your functional position. Sorry, Jenny, that was a lot of words.
Sorry, what was in the last word? Circumduct?
Circumduct,
Okay.
like a pose. Abduct, then circumduct.
Yeah.
But
Okay.
it's very important because older splint positions would put the person's hand in this position or in this position, which doesn't respect the biomechanics and causes more problems.
Ya, voy a hacer mi mejor esfuerzo. Dijo que el pulgar era siempre difícil en nuestros pacientes y que nuestros pacientes frecuentemente tienen problemas con la abducción del pulgar. Entonces, en nuestra cabeza tenemos una idea de lo que es la posición normal en reposo, y sobre esa idea que tenemos en la cabeza tenemos que superponer toda esta información respecto de los síntomas positivos y negativos. Y es súper importante, cuando estamos trabajando con la mano, el poder posicionar de manera correcta el pulgar, porque si solamente lo abrimos, lo que vamos a hacer es que podríamos subluxar la articulación carpometacarpiana y no le da buen sustento al pulgar, y tampoco respeta la anatomía y la estructura normal de la mano. Entonces lo que ella decía era que siempre le pregunta le enseña a sus alumnos que hay que abducir y como circunducir, una cosa así, es como ponerlo, abducir, pero también ponerlo en oposición.
Conducción del pulgar.
Sí.
En el fondo,
No sé la palabra.
es la suma de todos los movimientos, es la suma de la oposición, de la flexión y la abducción. Aducción, perdón. Cuando tú mezclas esos tres movimientos, logras hacer el movimiento de la circunducción. No un movimiento propiamente tal, sino que la suma de.
Oye, voy a
Bien.
activar,
Sí.
activo a las personas para que le pregunten directamente a Jody, a Tairi.
Sí, hay
Bueno,
Tai y Ángel, órdenes también.
bueno, hay dos personas, que es Mónica y Laura, que ambas hacen... Mónica pregunta sobre si es que puede repetir las evaluaciones, y Laura menciona dónde se puede leer más sobre el HIP y dónde se puede descargar el protocolo. O sea, son dos preguntas sobre evaluaciones en una. Se puede preguntar eso.
Ya. ¿Le querés preguntar tú, Seba?
Ya, ok. Jody, hi.
Hi, Sebastian.
Thank you for everything. Well, I'm going to ask you something about the chat. Monica said, can you mention again the assessment you use in your presentation?
Assessment, the assessment of spasticity?
Yeah.
Yeah. So the only formal tool that I mentioned was the scales for muscle spasticity or hypertonicity. So there are a few available. So the modified Ashworth scale is the one that is very commonly used. There is also Australian spasticity scale. I don't know if anybody has ever seen that, but there's also the Australian spasticity scale, which is very good. But the modified Ashworth scale has been in use for a very long time, so people are used to using it. It is just best used in conjunction with the tardieu, so that you're looking at the catch. And because really it's the tardieu and doing that fast movement that gives you an understanding of how much spasticity is there, because the spasticity is only a part of the hypertonicity and the overall amount of resistance that we're finding. So those assessments of hypertonicity and spasticity are important, but I think that because it tells you exactly where the spasticity is and the extent of the spasticity, so you can look at change over time. But even more important, I think, is the positive and negative features. And that is not a formal assessment. However, there is a more of a structured way of looking at positive and negative features through an assessment called the CAPM. And we can put some information on the website, Jenny, where there's an example, a way of using a structured method of looking at what is excessive, what is missing, what is the speed of the movement and the success of the movement, etc. So I think that the formal tools like the modified Ashworth scale and the Tardieu scale are useful, but we just have to remember that they're only looking at the body structure component and they're not looking at the activity level of the ICF. And it's really important that we connect those concepts from, you know, how much hypertonicity is there, what is the range of motion, all of that, and we're able to specifically connect that with the activity and what is happening within the activity.
Yeah. Dice que respecto de las evaluaciones, como lo revisó en la presentación, está la escala modificada de Ashworth y la escala modificada de Tardieu, y que son escalas que se usan hace muchísimo tiempo y que la mayoría de las personas las usan, pero que para el manejo de hipertonía es importante, como ella mostró en la presentación, el poder usar ambas en conjunto, porque la escala de Tardieu nos va a dar también una imagen de cuánto es dónde está la hipertonía y en qué articulaciones están afectadas, y decía también que, y como mostró en la presentación, en el fondo, poder identificar también signos de contractura. Decía que esas escalas son importantes porque muestra dónde está el compromiso y cuánto nivel de hipertonía existe, pero quizás es mucho más importante el poder evaluar los síntomas positivos y negativos, que no existen evaluaciones formales para poder evaluar estos síntomas o signos positivos y negativos, y existe una pura pauta de evaluación que se llama CAPM, es CAPM, y que ella va a pasarnos información y la vamos a poner en nuestra página web a disposición para que la puedan bajar. Esa escala mide la velocidad, el éxito y como el movimiento de las articulaciones en particular. Decía que no tenemos que olvidar que la escala de Ashworth y la escala de Tardieu solo evalúan en términos de la estructura corporal, pero no evalúa pensando en la CIF en términos de los componentes de la actividad y de la participación de las personas. Entonces, súper importante que conectemos esta evaluación, que es como más estructural y de la función corporal, con la participación y la actividad. Y lo otro que mencionó que me olvidé es que existe otra escala de espasticidad aparte de estas dos, de Tardieu y Ashworth, que es la escala australiana de espasticidad. Preguntaba si lo conocíamos, yo nunca la había escuchado, así es que también podemos pedirle que la ponga a disposición. Y lo otro que quería agregar, perdón, es que después puedo editar el video y poner, porque tuvimos un problema con los subtítulos, y agregar solo la parte en que yo muestra la evaluación y colgarla también en la página web para que después ustedes puedan revisarlo en más detalle. Jody, I just said, apart from what you said, that maybe we can, they would like to know about the Australian spasticity scale, if we can share information, and also that I will edit the video and just put in our website the piece of video where you were showing how to assess contracture and apply the Ashworth and the Tardieu scale.
Okay, sure. I think the other point to make is that assessing at those different levels is really important, and that connection and linking across the spasticity and range and the activity and the participation. And there are assessments, for instance, that are used to look at activity, but they are capacity assessments. So they use generally fairly standard movements and tasks, like picking up a block or picking up a pen or those sorts of things. And they're used a lot in research. However, we know that the limitation with research now is that we're not really getting information about performance, it's just capacity. So if you can change somebody's ability to pick up a block, that might not mean that they can use their fork to feed themselves. Yeah. So it's much more recognized now that we need to connect the changes in the upper limb to the goals in daily life. So I think that I don't think that necessarily the standardized assessments of capacity are very useful to you, that it's actually more useful to be able to look at a tailored assessment of performance of the occupational tasks that that person needs to do. And so something like the CAPM, which stands for Comparative Analysis of Performance, MOTA, it's very easy to translate and very easy to get into practice in another language, which is not the case for any of the other capacity assessments. But I think that they're not as useful, really.
Okay. Ya, dijo que lo más quería agregar que es súper importante que podamos evaluar en diferentes niveles y además de evaluar todos estos componentes como corporales, lo podamos conectar con este desempeño funcional. Que hay algunas evaluaciones que miden a nivel de actividad, como pensando en la CIF, pero lo que evalúan es capacidad en lugar de desempeño. Entonces, por ejemplo, describía algunas pautas de evaluación. Yo pienso como la escala 400 puntos, por ejemplo, en que hay tareas estándar en que se usan en investigación y las personas tienen que, por ejemplo, coger un lápiz o tomar un cubo, pero no necesariamente esa capacidad funcional se transforma en desempeño. Entonces, que la persona tome un cubo no significa que va a ser capaz de tomar el cuchillo y el tenedor para comer. Entonces, esas escalas que son de capacidad no nos dan información real acerca del desempeño de la persona. Y por eso es importante conectar estas evaluaciones con la meta funcional que tenga el paciente. ¿Qué más? Que hay otra evaluación que compara el desempeño, que es la que ya mencionaba, que es CAPM, que se llama Análisis Comparativo del Desempeño, y que es súper fácil de traducir y que sería súper fácil de usar en nuestro idioma, a diferencia de otras herramientas que son más difíciles, pero que ella encuentra que no es demasiado útil. Leo, no te escuchamos.
Está la pregunta de la colega Tairi Gómez, para que le habilites el micrófono.
Ya, mientras lo habilito, está conectado a Tairi Gómez. Está conectada. Tairi, ¿puedes activar tu micrófono y tu video, por favor?
Hola,
Hola.
el video creo que no me deja conectarlo, a ver, lo voy a intentar. No, de todas maneras parece que no me deja conectar la cámara, pero aquí estoy. Sí, había consultado con respecto a la experiencia de las reacciones asociadas en un brazo pléjico, ¿ya? Si tiene algunos tips, acabo de tomar el caso de un paciente que ya lleva 1 año de evolución de un accidente cerebrovascular isquémico, tiene una hemiplegia a nivel facio-brachiocrural y tiene reacciones asociadas frente al movimiento de su hemicuerpo derecho interno. ¿Ya? Al realizar fuerzas, movilización, ocurren estas reacciones de flexión. ¿Ya? En estado de reposo, él tiene su hemicuerpo pléjico, sin espasticidad, sin aumento de tono, y bueno, tenía en un comienzo algún tipo de patrón flexor, pero ha desaparecido con el uso de la férula de una COCAP. Si tenía alguna experiencia en esa área, algunos tips, como para identificar si hay presencia de contracturas, porque yo he evaluado Ashworth y no he evidenciado presencia de resistencia, ¿ya? De que haya resistencia ni en abajo ni de ningún otro tipo.
Ya. ¿La plegia era de qué lado?
Izquierdo.
Izquierda. Ya. Jody, she's a Chilean OT that is asking about your experience with associated reactions, like these reactions that happen when you are doing something with the non-affected body in hemiplegia. So she said that she has a client that has a stroke since 1 year ago, and he got like a left hemiplegia. When he's in rest, he doesn't have any increasing in hypertonia or anything. It's just very plegic. But when they start working, these like associated reactions start. And so at the beginning, he was with flexor flexor pattern, but now he is much better. But the problem she has is that when they are working, these associated reactions, when they are moving, changes the patterns of the plegic side. I don't know if my question is...
No. Yes, absolutely. We see that a lot in practice. And really the intervention then will come down to in what way is the associated tone impacting on performance. So if, as often happens, it's about if that hemiplegic side is being used as a stabilizer, then what does it need to be used for? Is it just for holding things down? In which case it might be splinting might be useful, or Botox, for instance, if the person needs to be able to stabilize just with a flat hand or that sort of thing, or arm, to be able to keep their arm down as a counterweight. If the person needs to be able to stabilize by grasping with that hemiplegic side and they're able to do that, then it may be that the addition of functional splints that help the movement pattern in the hand might be quite useful. But I've definitely had, so for these people who have not much hypertonicity at rest, but then associated reactions that come in, they're often in like group 1 or group 2A on the HIPM. Yeah. So you might start with, movement training. You might start to look at a functional splint, but sometimes with those people, something like casting or Botox will really help. So if you were to do, and because casting, and we haven't talked much about casting today, but casting is not just for lengthening contractures. It is also for reducing hypertonicity. And it can do that for a lot of people quite quickly. So that situation that Terry is explaining, sometimes we would get to the point of using a couple of casts over a couple of weeks to reduce the associated hypertonicity. And you will often see a difference after the casting in how much associated reaction you have, because it breaks up the pattern. Yep. So then for those weeks, the person is using their unaffected hand, but it's breaking up the pattern of the associated tone while they're doing it.
Yep. This is a kind of worms, Jody, but when you say, this is from my ignorance, when you say casting, inhibitory casting, it is a different type of casting? Like in terms of patterns and like the way how you position the upper limb?
Yes. Yeah. So serial casting, you've got a contracture. So you've got a contracture and your first cast is here, and then your second cast is here, and then your next cast is here. But if you're doing you can do inhibitive casting for someone who has full range, but lots of hypertonicity. And in that case, you would put the cast on in the resting position and keep it in the resting position. And often only takes a couple of casts to get reduction of tone if they're going to respond to that.
Yeah.
If there's lots of spasticity, you need to think about Botox.
Yeah. Terry dijo que absolutamente estaba de acuerdo contigo y que eso se ve mucho en la práctica, y lo importante es ver en qué medida estas reacciones asociadas que tiene el paciente impactan en su desempeño funcional. Entonces hay que pensar, ¿para qué el paciente está usando este brazo? Si va a ser que el brazo está muy afectado y solo lo usa como un apoyo, como para estabilizar la mano, por ejemplo, o para usar la mano plana y estabilizar, no sé, sujetar algo mientras está, por ejemplo, cortando o haciendo alguna actividad, o si lo que queremos es que haga prensiones con esa mano. Entonces, o si va a usar, o si lo que queremos es posicionar el brazo en una posición correcta hacia abajo para actuar como un contrapeso para estabilizar la postura. Entonces, todo depende en el fondo del objetivo funcional que vaya a tener. Decía que de acuerdo a lo que tú describías, que el paciente estaba en reposo sin tono, y que aumenta con estas reacciones asociadas, entonces significa que el paciente está en HIPOM, en este modelo de hipertonía, en 1 o en 2A. Y eso significa que uno podría empezar a hacer este entrenamiento de movimiento y a lo mejor usar alguna férula funcional, y también usar casting y, yesos y botox. Entonces, que los yesos no se usan solamente para los yesos seriados para estirar las contracturas, sino que también se usan con un efecto inhibitorio. Entonces yo le estaba preguntando, porque yo no sé hacer yesos inhibitorios, le preguntaba si es que estos yesos inhibitorios tenían algún patrón o alguna postura en la que uno posicionaba al paciente, y decía que sí, que no es lo mismo un yeso inhibitorio que un yeso que es seriado, que en el fondo en el primer tiempo va a estar así, después vamos a ir gradualmente como estirando o mejorando la postura, sino que estos yesos inhibitorios se hacían para las personas que tenían, por ejemplo, mucha espasticidad, y lo que hace es que como va a posicionar en otra posición, cuando está con mucha flexión, lo que hace es romper este patrón anormal. Entonces mejora y contribuye en inhibir el tono muscular o la hipertonía. Y que en general se posicionan en posición de reposo.
Jenny, ¿y hay el protocolo de los yesos respecto a los yesos, como para poder cerrar el tema de los yesos? ¿Cuánto es el protocolo de uso?
Para los yesos inhibitorios. Sí. He asked in terms of the inhibitory casts, what is the protocol? So how much do you use it? How often do you change it?
Yeah, everybody wants to know all of the procedures.
Yeah.
And in terms of, I think probably it's best to think in terms of guidelines rather than protocol.
Yeah.
Because you have to make the decisions about the person during the casting series. But in general, for inhibitory casting, so for serial casting, my recommendations would be to change the cast every 5 to 7 days, because you're waiting for metabolic turnover to lengthen the muscle. Yep. And often that fits in with services better anyway. But for inhibitory casting, you could change the cast every 3 or 4 days if that fits with your service. And usually for serial cast, you don't need to do any more than 4 casts. So I would not go any further than 3 to 4 weeks of casting. For inhibitive casts, it might only be 2 weeks or 2 casts, because you will know if you're getting a good response within the first 2 casts. That's when you get the biggest change in the first 2 casts, either for inhibitive or serial.
Ok, dijo que sí, que todos queríamos saber cuáles eran las guías, y que en realidad en lugar de pensar en tendríamos que pensar en guías o como guidelines en lugar de protocolos, y yo creo que hace la distinción porque en el mundo angloparlante tienen un montón de trabajo en torno a las guías y los protocolos y como las diferencias y como teóricas al respecto, pero yo creo que hice lo de las guías porque el protocolo uno lo sigue estrictamente independientemente de lo que pase, por ejemplo en los protocolos de tendones, y en cambio en las guías son guías, pero uno tiene que aplicar el razonamiento clínico y hacerlo individualizado al paciente. Entonces decía que para los yesos inhibitorios, ella, o sea, y lo que las guías recomiendan son cambiarlo a los yesos seriados entre 5 y 7 días, y que no hacer más de 3 o 4 semanas de yesos seriados, porque entre estos 5 y 7 días de cambio es donde ocurren los cambios metabólicos del estiramiento de los tejidos, entonces que lo haría de esa forma, entre 5 y 7 días y no más de 3 o 4 semanas seguidas. Y en relación al yeso inhibitorio, se cambia entre 3 y 4 días y alrededor de 2 semanas, y que decía que en el primer y en el segundo cambio uno observa, es como en donde uno observa la mayor cantidad de cambios. Entonces que después de aplicar este primer y segundo yeso, uno debiera ya observar cambios y ver cómo va avanzando el efecto inhibitorio o el efecto de yeso seriado en la modificación de tejidos blandos. Eso.
Después estaba Ángel dijo que ya le habían respondido su pregunta. Hay una pregunta-respuesta de Orlando Flores, que habría que darle micrófono.
Orlando.
Tenemos un infiltrado. There is an infiltrated person here, Jody.
Oh no. Hello, Orlando.
How are you?
Good, thank you.
I'm going to do the question in Spanish first and then in English. Is that better?
Yep.
Yeah. Sí, primero que nada, mis disculpas por infiltrarme. Yo no soy terapeuta ocupacional, soy kinesiólogo, pero estoy casado con una terapeuta ocupacional muy apasionada, por lo tanto voy a tener mucho cuidado de no meterme en el área del miembro superior, porque conozco los riesgos que eso conlleva. Así que en anticipación mis disculpas y la explicación de por qué las preguntas que voy a hacer son un poco distintas.
You're telling jokes, Jenny.
Yes, I am. I'm going to translate later. La primera es con respecto a los outcomes o a las mediciones y en el fondo, ¿de qué manera Jody piensa que los outcomes que se miden en clínica o en el research están efectivamente alineados o no con los outcomes que les interesan realmente a los pacientes? Y un poco lo que discutían antes de este outcome del cubo y de que si efectivamente eso tiene una traslación hacia algún elemento funcional. Entonces no tengo recuerdo, no tengo referencia de mis años trabajando con niños con parálisis cerebral, si había de alguna manera estudios que indicaran si es que había un agreement, una suerte de coincidencia entre lo que los pacientes esperaban como outcome y lo que nosotros los clínicos le estamos aportando o presentando, tanto como outcome para medir o como soluciones terapéuticas. Esa es la primera pregunta. Y la segunda es también pensando en mi cabeza de kinesiólogo, pero que trabajó harto años en un equipo interprofesional. Si es que efectivamente, yo sé que hay estudios, por ejemplo, que muestran que intervenciones más generales como el ejercicio físico, aeróbico o acondicionamiento en bicicleta estática, en tren, tienen algunos incrementos en la capacidad funcional, pero esa capacidad funcional habitualmente se mide a través de pautas que se enfocan mucho más al miembro inferior. Y por lo tanto no tengo muy claro si ese tipo de intervenciones, que son más bien general y pensando en cómo de alguna manera hacemos trabajo interprofesional, podrían efectivamente tener un efecto también en el miembro superior. Esas son las dos preguntas. Espero no haberme metido en ningún problema con ellas.
No.
Yori,
Yes.
well, first, I was presenting some apologies for getting here in the meeting, but I was just trying to check a little bit, and then I got lost in your presentation. It was so interesting, so it was kind of difficult for me to keep my work while you were presenting. Thank you very much for the presentation. And the other thing is that I'm not going to ask anything about the upper limb because, as you know, I am married to a very passionate OT. So
Yes, I do.
I'm going to put myself on risk. I'm going to just, make some general questions about, one is about the research and the other one is about how to work interprofessionally.
Yes.
Okay, so the first thing is that if you have any idea of what sort of outcomes the patient, the clients, their families are interested on while you try to improve manual function or that sort of outcomes. Many times we work for trying to control spasticity, control hypertony, and etc. But I am not really sure if that make a lot of sense for the clients and for the families. Probably the client or the family wanna write in the school instead of control the hypertonicity or the spasticity. So do you know if there's some research done on the degree of agreement between the outcomes that we as clinician researchers try to control in trials and the actual preferences of the families? And if not, probably if it's gonna be good to conduct a I don't know, a Delphi study or something like that for trying to check that agreement. That is the first one, and then I go with the other one.
Okay, so I don't know if there is specific research comparing what clinicians will be aiming for compared to what clients and families are aiming for. But I do know that the broader research in terms of experiential research, that's a whole sphere of research that we have around the experience, the lived experience of people with disabilities, yeah? And OT does a lot of that research. And so from that research, I think, has automatically come into research studies more focus on achievement of goals and that are meaningful and purposeful for our clients in daily life. So for instance, in the health system now, goal setting and the facilitation of participation goals is much more discussed at conferences and much more in the literature now than it would have been maybe even 10 years ago, I think. And most organizations will have processes by which they do that, but I don't know that it happens very well in practice. So when you say the goals that we would have as clinicians, I think that the encouragement and certainly the what health systems are trying to do is to make sure that what we're aiming for is the same as what the clients are aiming for, and the skill is in the facilitation of the goals. Because if you ask somebody who's had a stroke, what are your goals? Just like that, what are your goals? They often don't know, you know, because their goal is, I want my arm back. So I think that our skill then as clinicians is in talking to them about all of the things that can be achieved between the way your arm was before and the way your arm is now, and what is the next step on that ladder. So this is where I think those levels of functions that were in the presentation, the levels of function are very useful, because even still now, I will see clinicians assessing a client with a very dense hemiplegia after stroke and trying to get them to do you know the 9-hole peg test? Are you familiar with that?
Yeah.
Oh, I'm not a fan of the 9-hole peg test, only because that is okay as a measure of grasp for, you know, a proportion of people. But if you try to get somebody with a dense hemiplegia to do that, it just communicates to them that either we expect that you'll have that level of recovery, or it's a normative framework. And, you know, I think we need to have a framework that is about what is the next step, purposeful goals for people. So yes, I think that people often don't know what their goals are, and we have to get better at facilitating those goals. So I think goal setting tools are very important. But even when we use them, like I think the GAS, I think some people are familiar with the GAS.
Yes.
The GAS is okay, but you can still, as a clinician, if you want to, you can kind of funnel your client into putting something very specific that is actually a clinical goal and not a client-based goal. Yeah?
Yes.
So again, I think that's where the levels of function are good, because we can say, I think you will be capable of this level of function. Let me understand your life and your day and what's important to you. And then together we can negotiate what daily life goals might be meaningful for you that could be achievable. Sorry, long answer.
Yeah, I will translate that. I will translate that before she said the other. La primera pregunta en que Orlando le preguntó si es que habían investigaciones que contemplaran lo que al paciente le importa en términos y estar midiendo los resultados en términos de lo que es relevante para el paciente. Yo decía que ella no sabe si es que hay mucha investigación específica que relacionen o que midan los resultados en términos de lo que es importante para la familia. que sí, en términos como de la investigación más amplia, la experiencia de las personas con discapacidad es súper importante y que los terapeutas ocupacionales hacemos eso un montón. Que en términos del logro de las metas, hay algunas herramientas que facilitan el establecimiento de metas y el favorecer la participación de los pacientes y sus familias en establecer estas metas en forma conjunta, y que yo diría que más o menos desde hace 10 años atrás esto ha ido creciendo, y que las organizaciones promueven que esto pase, y que animan a los profesionales de salud a tratar de que podamos incluir a los pacientes y a su familia en decidir las metas de los objetivos de tratamiento. Que frecuentemente pasa que cuando uno le pregunta a un paciente, por ejemplo, con hemiplegia, ¿qué objetivos tiene?, el paciente no sabe lo que quiere, porque lo que él quiere es su brazo sano de vuelta. Entonces, lo que nosotros deberíamos hacer, y el desafío como clínicos, es poder explicarle a los pacientes qué es como la amplia gama de las cosas que ellos podrían lograr con la funcionalidad que tienen, y en qué nivel como de esta escalera de pequeñas tareas que podemos hacer, cuál va a ser nuestro siguiente paso. Entonces ella decía que, por ejemplo, actualmente se miden en Australia los niveles de funcionalidad con un test que es como de los 9 hoyos y como de perritos de ropa, y que a ella le carga esa evaluación, porque en realidad lo que estamos transmitiendo a los pacientes que es como lo que se espera de su nivel de recuperación, y que si uno pone a un paciente con una hemiplegia súper importante a hacer este test, que es de prevención súper fina, obviamente van a fracasar en el test. Entonces, que estamos como estableciendo que ese es el nivel de normalidad para el proceso de recuperación, y que eso es un marco que es equivocado, y que lo que debiéramos hacer es ver con el propio paciente cuál es el siguiente paso en términos de su propia funcionalidad. Que hay herramientas de establecimiento de metas, como por ejemplo el GAS, que se usa y se conoce en Latinoamérica, y que está bien, pero que a veces uno como clínico guía en este afán por ayudar a los pacientes que definan sus propias metas, uno los guía a que elijan un objetivo que en realidad es clínico, y que no nos dimos cuenta que no es significativo para los pacientes, sino que es significativo para mí como terapeuta ocupacional o como kinesiólogo. Entonces, es importante que nos sentemos con ellos y que nos dejen los pacientes entender a nosotros, en su rol del paciente como experto, cómo es su vida, qué hacen en su vida cotidiana, qué cosas son importantes para ellos, para poder establecer estas metas. Ya.
Okay, and the second one, Yori, is about trying to get back to work with OTs. So I didn't have enough in my first 10 years working with OTs, so I want to go back to work with you.
You love them.
Kind of. And my question is, if you know if there's a role or evidence showing that more general approach interventions such as exercise interventions, aerobic, treadmill, probably cycling, that has shown before to improve functional capacity. I read a couple of years ago probably a randomized control trial run by the Rosalind Boy group in the Children's Hospital.
Yeah.
And but most of those trials understand function as climbing stairs, like lower limbs tests. So I'm wondering whether via exercise, core stability, and so you can also contribute to upper limb function in a way that we can work interprofessionally, setting a common goal, and having obviously a clarification in our roles to avoid any kind of
Well, I think there's lots of ways that we can collaborate across OT and physio. Mm-hmm. And that's one way, in that we know that people with neurological conditions over time, they will sort of deteriorate with, and show age-related deterioration quicker than other people will. And so the general fitness and exercise and core stability is absolutely critical, and particularly as a platform for upper limb control, that's really important. So most of the clients that I see, we have the physio clinic here at UQ, and they will be seeing physio as well for exactly that reason. You mentioned lower limb.
Yeah, as a way of assessment.
And the measures of function.
My impression is that many times, if the leader of the research group is a physio, will focus like pretty much in that, and I think that's probably we need to think of more collaborative approach to the clients.
And particularly in terms of how function is measured, because the upper limb behaves in a completely different way to the lower limb, and completely different interventions are indicated, I think, because of the lack of weight bearing and everything. And, you know, the hand's really complicated compared to the foot. So yeah, ideally we need to be coming together with those goals, so that the more the core stability and the trunk control and you know, and those sort of more stabilizing aspects can be working in conjunction with each other. But I also think that when people are working in a team, OTs and physios in a team with these people, some of the upper limb interventions can be enhanced as well, because, you know, I don't think that we should sort of cut the person in half, with the OT deals with the top half and the physio deals with the bottom half, because really to do intervention with the upper limb effectively, you need two people, you need two skilled people. So when I do training, for instance, it's always best if the whole team, you know, the OT and the physio, the people in the team are there together, because they're looking at it on real interprofessional practice, is bringing both your lenses of expertise together, because we will be looking at the same thing and we will be bringing different expertise to that and different ideas to it. You know, so we have to keep the person as a whole.
Yep.
Thank you very much, Jody.
Thank you, Jody. La pregunta de Orlando era si es que existe alguna evidencia en que el trabajo que están haciendo como kinesiólogos, por ejemplo, de aumentar el ejercicio, mejorar la capacidad funcional de los pacientes, por ejemplo, en el treadmill o ese tipo de cosas, si es que esa mejora en la capacidad funcional se traduce a esta capacidad funcional como la miramos nosotros como terapeutas ocupacionales, y si es que realmente impactan el desempeño funcional de los pacientes. Porque muchos de los resultados se miden en términos, por ejemplo, funcional, si el paciente es capaz de subir la escalera, o funcional si es capaz de caminar tantos metros, que tiene que ver con la extremidad inferior. Entonces, yo decía que sí, y que bueno, que ella cree que el trabajo interprofesional es súper fundamental, y que hay muchas maneras en las cuales podemos colaborar los kines y los terapeutas, o los fisioterapeutas. Que los pacientes con condiciones neurológicas son complejos y que cambian a través del tiempo y tienden a deteriorarse en relación a la edad mucho más rápido de lo que nos deterioramos todos el producto de la edad. Entonces, que sin duda estas cosas como de condición física general, estabilidad como del centro, como estabilidad de tronco, como de la musculatura central, no sé cómo decir core, es súper relevante para el control postural, y por lo tanto, si vamos a trabajar, deberíamos trabajar juntos en ambas cosas, y que ella tiene la impresión de que muchas veces hay particulares medidas para el desempeño funcional, y que sin duda la extremidad superior se evalúa de forma distinta que la extremidad inferior, y que le parece que la mano es muchísimo más complicada de tratar, una mano neurológica, que un pie neurológico. Que las metas deberían establecerse en forma colaborativa y traer como estos dos pensamientos, estas perspectivas distintas de kine y de terapeuta, a poder tomar decisiones en conjunto y proponer ideas en conjunto, porque sin duda que el trabajar la estabilidad del tronco, por ejemplo, o la estabilidad postural, es súper relevante para que el paciente pueda efectivamente trabajar, no sé, estabilidad de cintura escapular y luego funcionalidad manual. Entonces, que ella cree que no debiéramos dividirnos en pedazos a los pacientes, y que la parte de arriba sea para los terapeutas y la de abajo para los kinesiólogos, y que en realidad en una práctica interprofesional genuina debiéramos sentarnos todos a trabajar en torno y con este paciente para poder informar con nuestras distintas perspectivas y hacer un plan de intervención. Eso. No sé si hay la última pregunta. Estaba Alejandro hace un rato.
No, ya no está. Está resuelta. Queda la última pregunta que plantean acerca de las termoterapias, si hay efectividad en torno a la elasticidad.
Yeah. Jody, the last question is about thermotherapy. With temperature, thermotherapy, if there is any evidence about the effectivity of thermotherapy. Or thermotherapy.
Okay, so the use of warmth, I think goes back to some of the neurophysiological research from earlier decades. So there isn't so much current research around that area, but I think most therapists will, that has continued to become part of the usual practice of most therapists, so that, and these days I think we're often informed by the family or the caregivers who will know if that person's hypertonicity particularly responds to, you know, warmth. So we might use, you know, wheat bags. Do you know what I mean by wheat bags, Jenny?
No.
They're like the that heat up, that you can heat up. Yeah. So things like that, or you know, those sorts of things.
Inside? Seeds?
Yeah.
Yeah.
Yeah. So those sorts of things can be incorporated into what we're doing if the person responds to it, and that would just be something that you would normally incorporate into your practice, similarly to other more traditional neurophysiological approaches, like, you know, providing pressure on the tendon when you're trying to range the limb, and those sorts of things that come from earlier stuff, like Margaret Rood, who was the theorist, R-O-O-D, those sorts of things. So that was used a number of decades ago, but some of those techniques, we would say they're oldies, but they're goodies. Yes?
Yes.
Yeah, because they will help in daily, but often they won't be enough. So once, when those techniques were used, if you think about things like other neurodevelopmental theories and neurophysiological theories, they were used by themselves. And so I think the key point there is that those sorts of techniques are an adjunct to other things that we will do by themselves, just like, you know, heat, ranging, all of those things won't prevent contracture by themselves, but they can help on a daily basis to be able to help the person move through range. And it's just that they often won't last for the person. So they're an adjunct to other things.
Yeah. Dijo que respecto del uso de calor, eso nos lleva de vuelta como a los componentes neurofisiológicos de la investigación, y era la investigación que se hizo respecto del abordaje de estos pacientes varias décadas atrás. Entonces son cosas que se han hecho parte de la terapia usual, y que lo más importante es que sea informado por la familia. Entonces saber, por ejemplo, si el uso del calor, ella me hablaba, por ejemplo, de estos packs que se calientan, o de estos guateros de semilla que también se calientan, si es que cómo el paciente responde a eso y de qué manera puede ser incorporado en relación a la persona, a cómo funciona en la persona. Ella hablaba también de algunas técnicas neurológicas que son, dijo que eran viejitas pero buenas, y mencionó, por ejemplo, las técnicas de Root y de Kabat, que son las que nosotros aprendimos hace muchos años en la universidad y que son súper antiguas en términos del abordaje en neurorehabilitación. Por ejemplo, usar presión en los tendones cuando estamos movilizando a través del rango para facilitar el movimiento con pacientes espásticos. Pero decía que lo más importante es saber que estas técnicas, si es que funcionan, no las podemos considerar usarlas por sí mismas. Es decir, que estas deberían ser técnicas que, si nosotros vemos que en el paciente ayuda, por ejemplo, a disminuir el tono, deberíamos usarla en conjunto con otras estrategias de intervención que van a facilitar el desempeño. Entonces, por ejemplo, si el calor o la movilización del rango ayuda al paciente, tenemos que considerar que esas técnicas por sí mismas, si usa calor, eso no va a prevenir que el paciente se contracture. Entonces deberíamos buscar estrategias y mezclar estas intervenciones para poder hacer que el paciente logre un mejor desempeño funcional. Eso.
Muchas gracias, Jody, por compartir el conocimiento con los colegas de Latinoamérica y un gusto haberte tenido una vez más en Chile. Y gracias desde el Colegio de Terapeutas Ocupacionales y agradecemos también a las 28 personas que todavía quedan acá en Zoom. Y gracias a Seba, a la Jenny, a Orlando que estuvo ahí en las primeras presentaciones también. Así que muchas gracias a todos.
Jody, Leonardo just said that on behalf of the Chilean Association and all the people that has been attending to the webinars, they say thank you very much for sharing with us this knowledge and for having you in Chile virtually. And they are very grateful. Yeah, that's it. Everyone in the comments also are saying thank you very much. Thank you for making it possible. So thank you so much.
Muchas gracias, everybody. It's a very lovely opportunity for me, and it's lovely to see you all. And hasta luego.
Que es una experiencia muy buena para ella también tenernos a todos nosotros. Y hasta luego. Eso. Thank you so much, Jody. We will talk soon.
Okay. Bye-bye. Ciao.
Bye.
Ciao, everybody.
Bye.
Chao a todos.
Chao.
Un millón de gracias por participar. Nos
Chao,
vemos
gracias.
en algún futuro cercano. Muchas gracias a todos.
Un ciclo. Que estén muy bien. Gracias por la invitación.
Adiós. Chao.
Bye bye.